Okay, so thank you all for coming. It has been such a pleasure to host this, to help plan this, and to see all of the same like-minded individuals come together under the umbrella of geomedicine. And it's so great to start my talk and not have to tell you what GIS is and your eyes glaze over when I say I'm a geospatial scientist. So before I begin, I feel like we all are on the same page with recognizing the value of EHR and geospatial data integration. I think that we have heard a number of pain points, and a lot of times those have been sort of roadblocks for you all to sort of go back and make this, happen in your own organizations. So I hope, if nothing else, I show you what we've done to sort of overcome some of those pain points, and then hopefully motivate you to go back and say, you know what, these pain points are not roadblocks, that we can overcome these, and these are, this is like any other challenge, you can get through it, and to go back to your leadership and really get the backing, because if there's any one pain point you must overcome, it is to get the backing of the senior leaders who can help give you the resources you need to make this happen. And so that's going to be your biggest challenge. And last, when I'm all said and done with this presentation, I hope to sort of push forward in your minds the true value of geospatial data integration within the EHR, because right now I feel like we've only sort of scratched the surface. We've talked about visualization and some basic exploratory analysis, minimal statistical analysis, minimal risk scores, taking into account hundreds of thousands of geospatial variables that define where we live and our health and our health care. And so I really want to sort of push you beyond that status quo of what you think GIS is into a more big data analytics, predictive analytics, modeling, taking into account so much more that's going on. So, if you haven't heard us talk about the determinants of healthcare, here is the last time I hope that we hear about this. It's clear to me that the World Health Organization, we in this room, we all understand just how important lifestyle and socioeconomics and demographics and your behaviors really contribute to your health and healthcare, and of course genomics. I want to make the point, though, that while the Institute of Medicine also understands this, they also have acknowledged in various reports the complications, sort of the roadblocks in making this truly integrate within an electronic health record and truly make this accessible on demand to the people who are seeing their patients and needing to make real-time decisions and information off of actionable insights. So I really want, if nothing else, for you to see, to start to see and start to influence others that these aren't roadblocks, they can be overcome. We'll show you how, and go from there. So before I get into some of the advanced geomedicine principles that I am extremely passionate about, and exactly how we've overcome some of the challenges, I want to sort of give an overview of where it is today in a little bit of a different context than what you've seen. So we clearly know that there's great potential, and we've scratched the surface with understanding how income and occupation might influence one's health or health care. And so geomedicine today really is about of starting to see small teams extract electronic health record data and unlocking the information that's been trapped in these rows and columns of, now our electronic health record, but before then spreadsheets and whatever else they had to use. And they've really started to help us identify spatial linkages, gaps in care, where they should be structuring their interventions, and then among other things. So visualization is important, and I don't want to take away from that. I just want to acknowledge that there are limitations in that. And just as a map is worth 1,000 words, it's also worth 1,000 questions of why and where else and who else. And so when you when you start to think about geocoding your records and making these on-demand visualizations, you have to start to anticipate that more questions will follow, and how are you going to answer those? And I hope to show you that. But Okay, let's get into where it is. So Esri, I pulled a bunch of all your story maps and stuff so I could show, because I love Esri. We use Esri a lot. And I think that, as you've seen, they do tell a good story. You see that, you've taken low birth weight data, you've pulled it, you've mapped it. Some people, this is a thematic map, but you'll hear the term hotspotting used a lot. And it shows you where something's happening that you know of the patients that you've touched, that have come to your system. You see the hotspots for them and only them. And then you can overlay, your providers and see where you might need to structure interventions and where the gaps in care might be. And clearly, it assists in making some sort of visual connection or linkage with two phenomena. So the blue are obese patient and the red are diabetes. And you see this and you say, wow, there probably is a linkage. But I know that most people that look at these maps can't do anything with it. They want to know why. Why is it happening there? And where else might it happen? And how do we do anything about it? And how do we really turn this into intelligence? And we really haven't tapped into that to the extent that we should. So once all these data sets get sort of extracted and prepped and integrated into a GIS, you and other data layers come into the picture, like median household income or occupation. You'll start to see some descriptive statistics about who these patients are. Maybe they live in low-income neighborhoods, or they'll talk about education or those sorts of things. And you'll see it all in static reports that, by the time that it's disseminated, it's probably a year since you pulled the data and published on. And when and if you do see statistical modeling, you'll see it on just a handful of variables. I've done a number of literature searches and can't find anyone who's analyzing thousands of geospatial variables. What's going on here? They come in with this hypothesis of, is obesity linked to proximity to fast food restaurants, and they test those things. But really, I want to sort of push you all to think, what is going on here? How much data can we possibly analyze? How do we unlock that to big data analytics software that's out there? So here's case in point. There's publication. They extracted data in some time frame. They looked at repeated hospital encounters for asthma. So you'll see this is the typical sort of workflow. They'll pull a cohort of patients from the EHR. They'll manually geocode them, which takes time, as you've heard, to clean addresses to get them accurately G-coded. Then they pulled local traffic-generated pollutants data. They had to undoubtedly process that, bring that into a geospatial software platform of their choice. They pulled census-derived poverty and median household income and looked at distance to the hospital. And in the end, they said asthma is associated with air pollution near the home. And all I can think when I see this is great, this is wonderful work, but what else is going on here? And who else and why and all of those things. So I feel like we have the potential to look at this. We just haven't yet exposed our information in a way that can be properly analyzed. So this one is looking at obesity linked to fast food restaurants, as I said a second ago. And of course, they examined home and work locations from participants and looked at proximity to fast foods. And they looked at proximity with straight up buffer analysis. So they drew a bunch of, 3 polygons around and did some nice little, in software statistical analysis within their GIS software, and found that, well, no, it's not correlated. Well, guess what? I live and work near a fast food restaurant also, and most of us do. And so it's not that it's not linked to something of this sort that identifies their behavior. It's just that they didn't factor it in. And, there's consumer spending data that says how much people typically spend on health food or gym memberships. There's there's, instead of just looking at distances, do they live in a high-density neighborhood? There's interrelationships among data that correlate, and we haven't seen a whole lot of look into this. This one's looking at the ability to stop smoking when you are close to a tobacco store. So they modeled just the proximity to tobacco stores, and it was through buffer analysis. And then they said, yep, if you live in walking distance to the tobacco store, you are likelihood to not be able to stop smoking. And I have a family of smokers, and I know that walking distance to a smoking outlet probably has nothing to do with why they smoke, but these researchers will not be able to know unless we give them data that they can perform actionable insight on. And the last thing is, because I had to throw this in here because we talk about CES all the time. So this one was looking at cardiovascular disease and how education and income and occupation contribute, and ultimately found that education was a factor. And that's great. I think that if you talk to most cardiologists, they might know that. And so when I talk to doctors and when I talk to people who want to turn this information into actionable insight, they say, well, what am I supposed to do with this? How do I turn this into action? That's really what geomedicine is about. So let's look at why it's this way. And I think I've touched on most of it, but right now, geomedicine relies on highly trained geospatial experts who are often funded by a larger grant that is not funding them to build this enterprise geospatial information analytics platform. It's really a larger grant looking at some condition, whether it's readmissions or diabetes or asthma. And then they have small teams of people who that study the clinical aspect and certainly conduct the interventions. And then there's just a small team of geospatial experts who, if they have geospatial experts, sometimes it's doctors who have just sort of picked up the software and trained themselves. But they have, and a lot of times it's students. And so these small teams of geospatial professionals, they come in and they think, okay, we got to get the data, we're going to go manually process this data, and we're going to get it into a GIS. And now what data do we need to analyze with it? So they talk to the clinicians. Well, I think we should probably look at income, and we should probably look at education. And so automatically, off the bat, they are introducing bias into whatever they're doing because they're coming in with this preconceived notion of what they think drives this condition that they're studying. And they go in, and because they can't go out and get hundreds of thousands of geospatial data layers and model it because time doesn't permit, by the time they've geocoded their electronic health records and gotten to this place where they can start analyzing, they only have time to go out and get a handful of data layers. So they go get the data, and then to bring it in, it's kind of cumbersome. They've got to go and make sure it's all projected and clipped, and you start to do the proximity analyses, and you start to run it through some more advanced models if you can. And when it's all said and done, the result, static reports, publishings a year later, and maybe some interventions, but probably not to the style that, BMW targets you in your mailing, So there's so much consumer data, there's so much lifestyle data, and so we're not really structuring our interventions half the time to all the data that's out there. So, and by the time that all of this is done, everything that you've learned is stagnant, and all of your efforts are lost because you've spent all this time getting data that you're probably not sharing back to the organization. You spent all this time manually geocoding records that you pulled from the EHR, and they're not getting fed back in. But if you do feed them back in, and then someone else feeds them back in, you guys use totally different methods that are inconsistent and can't be trusted by the next person. So how do we overcome this? I should say, before I say how do we overcome it, I should say this kind of reminds me of, Google. And before Google put Google Maps in your hands, you had no idea you needed it. And usually when I give these talks, I start by saying, how many of you use geospatial information today to drive your decisions? And most people are like, I don't even know what geospatial information is. And so I say, how many of you have a smartphone? How many of you had to figure out how to get here today? You use geospatial information. What if Google would have, if you said, how do I get to the conference facility? And Google said, okay, user, here's your address in a tabular file. Here's the road network you're going to need. Here's the traffic data that goes with it. Here's all of the hotels in the nearby area. Figure out which one you're going to. And take that and put it in a GIS and figure out what you want to know. How many people would ever use geospatial information? How many GIS experts would use it, other than the geeks like me who did that before Google? But there aren't many of us. And so if you want this information to be consumable and usable by mainstream, by doctors, by nurses, by people, you have got to present it. You have got to push out the information, the intelligence off this data in a way that is usable and is actionable at that time of encounter. Okay. So now, how do we do that? Well, my whole mission is to how do we give intelligence at the speed of thought? And so, of course, we've identified the pain points as being, man, our addresses are messy, and our EHR vendor should do something about it. And the reality is you don't have to wait for your EHR vendor to do something about it. Most of you who have EHR systems, you have an enterprise data warehouse. So within that enterprise data warehouse, first and foremost, I think you should start bringing in some of the other data that represents these other socio-determinants to health, okay? So Esri has a ton of this data. MapInfo has business points. There's a plethora of data out there if you want it, and your mission as a strategic vision of an institution should be to go out and get it all and put it in. But that's not the stopping point. You don't want to just have data, right? We've heard today, we don't need more data. That's where integration comes in. Because I'm not talking about collecting GIS data and geocoding addresses and serving this stuff out. I'm talking about serving information. So how do we do that? We clearly have to clean our addresses, and we have to standardize it. And there are ways for an EHR system to do this automagically, but until they get on board with you, you can do it. You can bring that into your enterprise data warehouse, and you can, each night that you have a new address that hits your system, there are ways to automate the address standardization and geocoding, and I'll sort of tell you what we've done. But there's lots of software solutions out there. You just have to want it bad enough to go get it. And in order to want it bad enough and go get it, you're going to have the strategic planners and the people above you to be on board with you and see the importance. And that's going to be your biggest challenge. So the other thing that I know we've talked about is the notion of being able to maintain address history, and we do that at Duke. We before we went live with Epic, we had 10 plus years of data that captured addresses each time a patient touched our system. So address history is nice, being able to maintain when they had an address, because after a while you're going to relate those addresses to geospatial data, and you want to make sure you're relating an address in time to a time in which that geospatial data is accurate. For example, if they had the address in 2000, you don't really want to be tying it to 2010 census and using it the same way. You'd probably want to use 2000 census to get an idea of what was going on at that address at the time of that encounter that a patient had. So multiple addresses, clearly important. I think our EHR vendor is set up to collect it. We're just not collecting it. It's not their fault. And so, so we need to know the residential mailing address. We need to know the work address. And more importantly than all of that, it needs to be part of the workflow, mandatorily collected, a physical address. Billing addresses are important. I mean, ultimately, that's how we get paid. And if they can standardize that and verify it, and we can send our bills to the right place, that's great. But for population health, we need to know where that patient lays their head at night. And if you're a student and you're providing your mom's address, that's not adequate. If you have a P.O. box, that's not adequate for this level of research. And so at the very basic level, at the very first step, we've got to start collecting all the address data and really prioritizing the physical data, the physical address, along with that mailing address where they want to pick up their bill, if they want to pick up their bill. So I've defended the EHR systems, but seriously, my bank, when I went to change my address, told me that my address was wrong and standardized it right then and there. So there are ways to do this, and it's very simple, easy, cost-effective solutions that can be done. Okay, so here's the missing link. Here's what we haven't heard a lot about. So we know we need to get the data. We know we need to geocode. I've identified that we have overcome the pain points of doing that, and I'll speak a little bit more specifically about our solution later. I was trying to make this a little bit more high level. Anyway, but I think you guys want nerdy details because you're like me. So I think that we need to take it a step further. So if you have where each of these little colored dots are fast food restaurants and different businesses, and you have all of these layers that characterize block group neighborhoods or tracts based on their socioeconomics or demographics or lifestyles, I think we need to take it a step further. And that is where you look at a geocoded address and you automate the computation of the relationship calculation between. So as our previous speaker mentioned, he, in his risk score, they're planning on looking at distance to hospital. So in order for him to automate the distance to hospital calculation in his risk model live in a real EHR system, he's A, going to have to automate the geocoding. He's B, going to have the geocoding of the hospital there. And he's then going to have to, at some point, calculate that distance for every address. Now, you can try on the fly to calculate these distances or enrich these selected addresses for a given cohort and then enrich data. Or you could pre-calculate. And the benefits of pre-calculating is that it all happens in a nightly batch where you've brought in this data, you've processed it, and now you've truly integrated it, because for every address, you know that address is distance to a fitness facility, you know what that address, his neighborhood spends on healthy food, you know whether or not they're close to any ED, you know for any given address hundreds of thousands of geospatial data points alongside that clinical information that is being captured, that 10% that we've spent millions on capturing. You can now capture the rest, the 70%. And then genomics, well, that'll be another great venture. So for us, this integration has resulted in the on-demand visualization that we have shown to be so important to sort of show people where and to first bring up that, first question of, well, where are things happening and where do I need to put people and allocate resources? So when you have things geocoded at an enterprise level for every electronic health record address, then it's just a matter of, Dr. So-and-so wants to see his readmits last month and where were they? And so you get that. You get that on a map. You get it in various ways. There's lots of technology out there to pull that, and it can all be done behind your secure firewall. Oops. And then with that, you also get the ability that as researchers come in or doctors come in and maybe they have a set of readmission patients that they want to look at, but they really want to sort of do something about those that may not have access to certain things in their environment. Now, instead of pulling the EHR data, manually geocoding it, pulling in those things in the environment they may not have access to, and then having to do these specific geospatial techniques to query by location and query by attributes all inside of GIS, now it's a SQL query. All that data is just a column. There are hundreds of thousands of columns in a database that say these addresses are within this distance of all these features. So I can say who of my readmits are outside of a 10-mile radius, or outside of 10 miles of my hospital, and they live in these types of median household income lower than this, and it's all a SQL query that happens at the speed at which you've asked the question and pulls it back at that speed versus having to go into some magic cloud and computing it all. But more than that, now you can consume this information. You can push this out to your BI dashboards, your non-specific GIS software. You can still pull it into GIS software. There's still going to be those of us who want to do that. But you make it more mainstream because you make it consumable. SharePoint, SAS, Tableau. I should whisper Tableau, not Tableau. Esri. And Crystal Reports, business intelligence, all of those things can now consume this in a way that there's all sorts of on-demand visualizations in these various tools. And so now you'll get the behind the scenes as you've filtered a cohort and as you've visualized it in some of these tools, you'll get those explanatory, those descriptive statistics on demand because you can summarize for your selected cohort what their median household income is, what their distance is. You can pass it into SAS, where you can then mine through thousands of geospatial variables along with the clinical variables and let advanced algorithms decide which are statistically relevant to your problem set. So now you're bringing the power of predictive analytics to geospatial and to geomedicine. And the way you do that is you have to serve this information in a way that can be consumed by some of these other software platforms that people are used to using. And so again, this really sets us up for on-demand geospatial predictive analytics as well as predictive analytics in general. So here's a Gartner press release, January 2014, that says organizations that use predictive business performance metrics will increase their profitability by 20% by 2017. So as we begin developing real-time predictive models for our readmits, our heart failure patients, our heavy ED utilizers, we should not limit this capability to only the 10% of what influences health and healthcare. And the only way that we can't limit the only way that I can see that we get around limiting it is by exposing this information and serving it the way that we are. So we've talked a lot about ROI and how it's so difficult to quantify. But before I go into this, I want to say I'm pretty sure our EHR system was pretty hard to quantify our ROI before we invested in it, right? Did anyone know how much we'd save and how much it would make us better? We had theories of how much greater it would be to not have paper cuts from analyzing data and in paper charts. We knew that it had a lot of potential, but we didn't really know. I mean, that's what meaningful use is somewhat about, right? To see how we've benefited from deploying these. So if we can do that for 10% of what drives health and healthcare, we should be able to do that without this promise of huge ROI, even though I feel like there is, and I think you all realize the value and the promise that it holds. So enterprise integration, in my opinion, reduces all that time it takes to disseminate that information. And I think it'll help you increase value quicker, which is what you want. You don't, if your organization invests in building this integration at an enterprise level this way, they're not going to want to see that it's going to take you 5 years, and then you might have some use cases to show that they've been, investing in this, and you might show value. This is the selling point, in my opinion. You're reducing the time that it takes to bring geospatial information into the clinics, into the people who need it, and into the areas where people need it, and you're increasing the value, ultimately. So, old way, paper maps. New way. I love Steve Jobs, so anytime I get to put an iPhone or something in that, I think he was a great innovator, and I think that all innovation comes at a swimming upstream battle, and people a lot when he put the iPod out there, people didn't think that you should be able to buy one song at a time, and I think he did swim against the tide until people realized that, you know what, we didn't know we needed that, but we do, and we didn't know we needed on-demand geospatial analysis through Google Maps and all of those things, but now we do. This is no different. Sometimes people in this industry don't realize what they need until you give them something and they say, wow, could we add this? Can we do this with that? And so some of it's about taking that initial step, swimming upstream, doing these proof of concepts and getting it out to them in order to then have it refined by the subject matter experts who really drive the use of this. So then, that was a tangent, I know. I'm good at that. So the new way clearly is more operationally efficient because it's fully automated. You can, through ETL processes, constantly update and grab the most up-to-date geospatial data sets that then get integrated into your electronic health record address database. And the beauty is that now, because you've done it for everybody, it's project agnostic. So anybody with any health concern, whether or not you're studying asthma or readmits or diabetes, you can pull a cohort of patients and get real-time analytics, visualization off of this data because of that. And in the end, you're really empowering your end users because you're going to give them information through systems that they know how to use and in ways that they can act on versus having to get a GIS person to go analyze this and give you some answers a year later. And with that, you get integrated best practices. You use only the cutting edge in terms of geocoding that's out there. You use only the best data that's there, and you have the impact of making sure that is what it should be at an enterprise level. And then, most importantly, all of this happens behind your secure firewall. So I can't tell you how many times people tell me that they geocoded their addresses by stripping the PHI out of it. An address by itself is PHI. So they sent it off to an API and geocoded it, and they disseminated PHI. So it's so important that, geocoding isn't novel, first and foremost. It is a pain in the keister when you have messy addresses, but there are solutions, and there are solutions you can deploy behind your firewall to get this done. And so, ultimately, I think that all of this reduces costs because while it's an upfront investment at an enterprise level to develop this infrastructure this way, it's cheaper over time because you don't have multiple grants paying multiple teams to do this in silos and never feed it back. And ultimately, because it's automated, you have a lower FTE overhead to maintain. Because once you get the data and you automate it, you don't need a bunch of geospatial experts out there manually clicking buttons and doing things with it. You need analytics. And so I think that this puts you in position to have more capability in less time. I think ultimately it increases your reaction times to different phenomenon. I think it yields more opportunity to save time, money, and more importantly, to save lives. And at the end of the day, you have improved insight. You have something that's easily consumed across multiple platforms. You have machine learning opportunities, and you have insight at the speed of thought. You have the ability to take into account hundreds of thousands of geospatial and clinical data variables that truly capture what's going on. You go at it with an unbiased approach. So none of this, I think obesity might be related to fast foods. Let me check on that. You can sort of deploy algorithms that and spend your research and development dollars in deploying algorithms that are safe, that don't give you information that make you think that one causes another, but to really enhance your statistical efforts in order to get answers that take into account a more complete picture of what we're looking at here. And so more than just where and who, now you're going to get why and how and who else and where else and all that predictive analytics has to offer other industries, we will be able to see, and all of that will lead to actionable intelligence and improved insight. So our status, this has kind of been our timeline of what we've done, and I'll give you a little bit more detail. So a couple years ago, we automated the address standardization and geocoding within our enterprise data warehouse. We completed it July of 2012. It runs nightly on any new addresses. We use SAS Data Management Studio, by the way, and through SAS Data Management Studio, it's more ETL-like, so it's great because you can schedule these jobs to do. And you can license data packs within, like the USPS data pack and the TomTom geocoding. Using USPS as your source for cleanup, I don't know why anybody else would do anything different. They're the ones that know what the most up-to-date addresses are, and they've already went through great pains to clean it. So to be able to pass your unclean version through a USPS data pack behind your firewall and match your unclean version to a version that is verified and clean, and pull back all of the results, not just if you didn't have city or you didn't have state or you didn't have zip code, it will fill all of that in for you. And then to use something like TomTom, which is an industry standard, these people make their lives and professions with collecting all the most up-to-date information that goes out into your mobile devices, your cars, and they're constantly updating. They're constantly getting the best streets, the best parcels, in order to deliver the highest accurate geocode. So why would you try to undertake that when it's already been done? Why would you go get a street reference layer that's going to be outdated by the time you get this done manually? Use something that is refreshed, and that all it takes is for you to push a button and say, refresh it, because they've refreshed their reference sources. And so we do that. We pull in the refreshed USPS data because people are building new addresses all the time, building new homes all the time. So quarterly, we bring in the new USPS data pack and the new TomTom geocoding with all the most up-to-date reference layer, and we hit go, and 10 hours later, every 6 million addresses is refreshed. And all of it, again, runs behind our firewall. 90% of the patients we've seen in the past 10 years have a current address that has been verified and standardized by the USPS. I have to say, we get a lot of garbage. You guys know that. You've talked about it. That's been your pain point. But you can automate that cleanup very nicely. 83% of those we were able to have geocoded by the TomTom address point database. Well, that's great. So 83% of those with high precision rooftop or street level accuracy. And the reason for the 7% difference between those that were standardized and those that weren't geocoded were because they were non-physical addresses. These are things that we can solve on entry. Require it be physical, along with the mailing. We need the mailing, that's great. But we need a physical address. A P.O. box, a rural route box is not sufficient for the type of analyses we want to do with this data. So with that, we had a homegrown business intelligence tool called Deduce, but we were able to serve immediately this geocode information into this tool so that as researchers and hospital administrators and everybody who comes into it to deduce, they will filter cohorts of patient based on their diagnoses and their encounter level information. And they can do all that through deduce without having to understand the underlying data model. So it's nice because they get access to, the people that they want to study without necessarily having to, manually try to figure out how to get the data out of our enterprise data warehouse. And so when I was brought to Duke, our director at the time said, "Can we just see dots on a map? Can you do that? Can you automate the geocoding? Can we just see these people?" And I just looked at him like he had 3 heads, and I said, "Yes, but that'll only take me a couple of months. So what am I going to do after that?" And he said, "Well, what do you think?" And I said, "There's so much more we can do with this information." And that began the learning curve and the process of me sort of saying, here's what we can do, here's what we should do, and getting the backing of him and now my manager, Monica Horvath, thank God for her, to support you, to realize innovation when you see it and to support it is something valuable. So with that, we have on-demand visualization. We can, it's all secure behind our firewall. And I want to mention that any platform can use this. You don't have to have a deduce. You can put any BI dashboard on there that has mapping capability. You can pull this into Esri portal. You can do so much with this. So we have coded in the ability to do point distribution and thematic map types available. And most importantly, when you come in and you filter a cohort, you only have access to visualize the granularity that you're authorized to visualize. So if you're coming in with IRB approval and you don't have access to see dots on a map, then you don't get to see dots on a map. And so you get the granularity that you're allowed to see. But the beauty of the integration, even though I'm not there yet, is that you can do analysis real time. Just because someone doesn't have access to see a dot on a map or to pull a dot on a map doesn't mean real-time analytics can't be run on those on demand, behind a firewall, invisible, and information be reported out at the aggregate level that they can see. So we have been in process of developing this enterprise geodatabase within our Oracle database that houses our electronic health record information. And so we've sort of set some standards that while we try to collect everything at a national level because our patients span the U.S. and the world for that matter, but we try to, since we USPS geocode and address standardize our address only to the U.S. and not to the world, we said it'd be nice if we start getting coverage of data, lifestyle, segmentation data, demographic data at a national level. And when we can't afford to do so, like some of the business data that we have acquired, we won't go any less than North Carolina. And so at the very least, we enable full analytics at the North Carolina level with some of this data that we bring in. And with this, you can, we use Esri, of course, to use their spatial ETL tools to prepare this data. So at any point in time, if I become the girl of a Mack truck, someone can come in behind me and everything's very well documented about all of the transformation that went in from getting this data from its source into pushing it through these spatial ETL tools in order to always have that refresh and that up to date. People are frowning. I didn't mean I was going to become the girl of a head Mack truck. So with that, we have, right now, we have in our geospatial data warehouse 10,000 demographic socioeconomic factors. We have the North Carolina business data delineated by SIC code. We have started pulling consumer spending, lifestyle, segmentation data, crime. We have not yet taken the next step on it's important to say, we've also, as part of the spatial ETL, created derived data sets. So sometimes, like let's say if you pull a cohort of diabetics, it may not be useful in a model to present the count of people in their neighborhoods who were elderly. A model may not know how to do that, how to interpret that. But if you say the percent of people in these people's neighborhood, or they're 20% elderly, it might be valuable. Or they live in a high quartile of elderly patients as compared to the rest of the population. So through spatial ETL, you not only prep this data for analysis, but you can derive new data elements that can then be presented to your models in a more on-demand fashion and be meaningful. And so then we, with census data, clearly it's very easy to automate that relationship building because you're just talking about a database join at that point. Through the geocoding process, we get their block group FIPS code, we get their tract FIPS code, and so any data we pull at that level of granularity is easily joined, and there's not much more integration that's needed. When you're looking at proximity to roads and parks and distance to fast foods and all those 10,000 businesses that are in your map info business point data, you actually need to do a little bit more to integrate. You have to build additional spatial ETL tools that look at each address and calculate that distance and store it in a way that can be accessible through your traditional Oracle or traditional database. So what you get is these new columns. Again, I think I've covered that enough. And then, of course, with all of those new variables, we have served it through Deduce Geo because it's living and breathing, but we plan to do this through our BI dashboards and through other tools as well, where as people are visualizing certain phenomena that they're filtering, that they can also then select only those that have low income and identify those on a map without ever needing to really do the spatial analysis on demand or take it out, move the data to their personal laptop, geocode it on some API, using some API, and then, bring it into ArcGIS and do these, location queries, sort of ad hoc. And then through Deduce, but it's also available through data request right now, the ability to export all these 10,000 new data elements along with any of the other clinical data that they have access to these cohorts, so that now they can just simply export to SAS and start using a little bit more advanced algorithms in order to mine through all of these data variables to see which might be statistically significant. And then, of course, we do, here is sort of an example of what a BI dashboard might look like. But through Deduce, we do offer some ability to visualize this data as well. All of this needs development, but there's only one of me. And so I have to sort of develop something, and then I have to push it to Deduce for these user communities, and then I have to go out and get researchers to use it and really sort of show the value of it. And so then you repeat the cycle. So right now you can overlay your cohort on top of some of these other median household income and other neighborhoods, and you can see the distribution of your cohort in relationship to whether or not they come from what their median household income is of their neighborhoods, and how many of them are within low income or high income. And then we've started delivering some pilot use cases for on-demand predictive analytics. We are working with SAS to deploy SAS visual analytics on top of this data, so that as you have sort of the typical BI reporting functionality, and you can go in and you can filter cohorts by clinical data, but you can also start to explore relationships both with the clinical data and all the geographic data through visualizations. You can then, if you find something interesting, create dashboards that then get disseminated via the web. It all happens on demand in memory processing. And so we're really excited to start playing with this technology as a way. And another thing, you can store SAS procedures that would go through some of that factor selection. So if you're tired of one-offing and saying, are my obese patients related to proximity to fast food, we're looking at ways to automate, helping you sort of refine thousands of variables and say, maybe you should look at these, and sort of leave it up to the investigator to do their due diligence from there. So early use cases, how am I doing on time, Shelley? Okay, so early use cases of this integrated EHR data or these automated methodologies. I love this project because it's kind of how I've been able to do what I'm doing, and that is, as I have an idea, as I develop something, I'll inevitably have a researcher say, "Man, we're working on this. Can you help?" And it's great because we want to help each other, and so whatever I do to help them, I make sure I scale it up. So if I develop an automated methodology for their cohort or for their problem set, I scale it for the entire enterprise worth of patients. And then if they need data that we don't have, I go get it, but I don't just give it to them. I integrate it within every electronic health record, and then I disseminate that for their piece. And so it's really a nice working relationship, and this was one of the first that where we really sort of started unlocking some of that potential of geospatial predictive analytics and consumption of these thousands of variables that I had been creating. And so what this was is we have mobile health at Duke and some guys in the field who are very well up on wanting to use wearable devices, wanting to develop real-time interventions and understanding how behavior can be captured through these wearables and how biometrics can be captured, and time and location, because most of these devices are location enabled. How can they start to deliver real-time interventions when the patient has an urge, when the patient is in a location where they're statistically likely to smoke based on their prior behavior? So how would you know that if you didn't have all of these variables the way that I've shown you? So what we did is we took, as their participants had logged where they smoked, we wanted to first see, could we do a baseline? Could we say for all smokers in this study, I think we started with 17, and they monitored every second of their life where they were. And every time these people smoked, they hit a button, and every time they had a craving, that was monitored. And so the first step was, can we take this data that we have, can I enrich it with all this geospatial data that's out there? And can we analyze what's going on for all of these smokers in general? Because you want to start somewhere when you have an app geared towards smoking cessation or, diet and fitness. You want to start somewhere with some baseline signature, right? So we took all 17 and we said, okay, here looking at where they're smoking and where they're not, let's run thousands of geospatial variables through a logistic regression model, and let's find what's statistically significant, what's contributing to this behavior. And it selected, I have other presentations that go into detail, but I was trying to keep this more summary, but I can't help but getting into the details. So it came back with, let's say, 35 variables that influenced their behaviors, where they were in proximity to restaurants and bars, and they weren't near, cemeteries, and they weren't near a church, and little things like that, clearly a smoker isn't thinking, oh, I'm not by a church, so I should smoke. But there are ways in which you behave that you don't understand what's influencing it, and healthcare providers and we in general don't understand why. And in order to better monitor that and understand it, we've got to take into account the whole picture. So this really did that. And then not only did it do that, but now it breaks the mold, because what you see up there is not a hotspot map. Please don't brag about your hotspot maps anymore. Let's move away from hotspotting and looking at where things happened in the past. Let's move towards, this is where they happened. This is what influenced why they happened there. And here are other areas that are statistically similar to those areas in which that behavior happened. So if you notice, green dots where they smoked red being sort of where they're likely to smoke, they didn't necessarily have to be in the red to know that they're likely to smoke there. Those signatures are similar in geographic space to where they already engaged in that behavior. Now imagine this real time where you can deliver a just in time and just in place intervention, and imagine the possibilities of machine learning where now as you, user A, come in and you have your own points to this, and now it learns your behavior, it models it real time against this, against all these variables and predicts where you are more likely. The possibilities, we haven't even scratched the surface. And I know that in order to get there, we have to get through these pain points. But my point is that you can if you want, because you can do anything you want to do as long as you want to do it. And as long as you have someone like Monica and others above you that realize the value and are willing to allow you to go with it. So we have another investigator who, Dr. Dev Anderson, who's an epidemiologist, and he talks about C. difficile and how it used to be a hospital-acquired infection. And now more and more, they're seeing these infections come into them when people are coming in for the first time. So they didn't get it in the hospital. And so he has no idea. He doesn't have a null hypothesis. He doesn't know what on earth could be driving this to be a community-borne infection versus a hospital-acquired. So he has, we've delivered thousands of geospatial variables along with some of the clinical variables that he wanted. And he's in process of statistically modeling these in order to help uncover patterns. And so one of his quotes, he says, I'm going to skip down a little bit, he says, "To be honest, we don't know what we're going to find, but it's exciting to think that we now have tools to open the lid on a question and see what comes out." Dr. Eric Wong, he's an inaugural faculty member in the new division of translational bioinformatics. We have recently given him thousands of geospatial variables on a subset of the Durham, or on the Durham population, in order for him to look at the clinical versus, along with the socio-determinants. And I love his quote, so I'm going to read it. He says, "Though I'm trained in genomics, my clinical training consistently tells me that relevant signal in our patients is not only cell or organism autonomous. Their health, and therefore the signal we model against, is inextricably linked to their community, their surroundings, and their socioeconomic context. I will take signal wherever I can get it, whether it's molecular, conventional EHR, mobile device, or GIS." I love this. And we wouldn't be able to allow him to detect these signals if we weren't doing it this way. Dr. Monique Anderson, who I think is here somewhere, she's a cardiologist, a researcher at the Duke Clinical Research Institute. She is interested in using EHRs for pragmatic clinical trials. So she and I have been working together to take the early geocoding work and some of the data that was integrated in order to sort of complete the electronic health record where it's incomplete. So we're doing some surname geocoding based on where race is incomplete for electronic health record, looking at the surname that the census puts out of what race they're likely to be, and combining that with what the census says the proportion of people are who live in that area who are various races. So we're looking to sort of help complete that in the electronic health record, and then ultimately we have, and this part is now complete, where we have used a research methodology developed by RTI that computes socioeconomic status based on a number of demographic variables. So instead of just looking at median household income or occupation or education, this sort of takes into account a handful of them, and it ran through principal components analysis, but in the end, it gives us a way to, at an enterprise level, basically give you a number of this patient lives in a low socioeconomic neighborhood versus a medium versus a high. And so she hopes to use this ultimately, I'll read her quote too since I read the others. "Pragmatic trials will involve broad populations, including more minorities and lower CES patients that than commonly seen in traditional clinical trials. So knowing whether treatments or interventions work in these groups are critical, yet few health systems comprehensively collect these data. Geospatial methods help us to study this information when not collected directly. So just some noted pain points from the summit over the last day and a half. The curse of GIS is we have to clean data all the time. That has been the curse. We can overcome it by developing these spatial ETL tools, by automating geocoding, by bringing this data in and integrating it so that when you clean it once, you don't have to clean it all the time. You cleaned it once. You've automated it. It's done. We don't need more data. We need sustainable solutions that use all of the data. This is it. This is how you do it. This is how you factor in all of the data. There's so much data out there, but unless it's integrated, you can't begin to analyze it in the way that's needed. Human cognitive capacity, Esty talked about how we can only all this data is increasing, but we only have the capacity to cognitively understand, all that we've ever been able to understand when we cognitively look at it. That's why predictive analytics is so important, and that's why every other industry in the world is using it. And that's why as we begin to develop real-time prediction algorithms, that we understand how this information, all of the data needs to get served to these algorithms. Because currently, I haven't seen one risk algorithm out there for readmissions or others that take into account, that ever consider hundreds of thousands of geospatial data elements. Usually we're talking about a handful of factors that get analyzed, and it's because it's difficult. It's justifiably difficult, and it's only for those trained and know how to use a GIS software system, but it doesn't have to be that way. Google gives people geospatial information in seconds through their Google Mapping app, and they didn't have to know how to do any of it. We can do the same thing. So if we could ever get analytics to start analyzing the data, we'd be light years ahead. A single champion is not enough in upstream swimming. So I have been upstream swimming for a couple years, but it's a mission I chose to do because for some reason I like to swim upstream. I have no idea why. It's been my whole life. But I find something rewarding in a challenge. And if ever in my life I was ever given a challenge where I could say, take the easy way, wait for your EHR to do it. Take the hard way, go against everybody who thinks they know something about it and do it, and show them the useful, it always is more rewarding in the end. So that's where we are.